Assalamu alaikum doctors. Today I am going to teach you neonatal jaundice. So first let's understand the term. What is neonate? Neonate means from birth to 28 days period. That is neonate. And what is jaundice? Jaundice means when serum bilirubin level exceeds in blood. So as a result, there is yellow discoloration of skin, mucous membrane and sclera. So what is jaundice? Jaundice means when serum bilirubin level exceeds in blood. So as a result, there is yellow discoloration of skin, mucous membrane and sclera. So when clinically jaundice appear when serum bilirubin level is more than 5 mg per dl. So clinically jaundice appear when serum bilirubin level exceeds from 5 mg, that is more than 5 mg per dl. So it is important. So when serum bilirubin level is more than 5 mg per dl, so there will be manifestations of jaundice. So there is another important question: what is the most common site of jaundice? So most common site of jaundice. So that is called as sclera. So it is important. So the most common site of jaundice is sclera, but the people who have a black skin and that condition, the most common site of jaundice, that is not a sclera. And that condition, let me write it, in black skin people, the most common site of jaundice, that is heart plate. So don't forget it. It is important. The most common site of jaundice is sclera, but in black skin people, the most common site is heart plate. So what is the index that is used for the neonatal jaundice? So the index that is used for neonatal jaundice, that is called as index used for neonatal jaundice. That is called as Kramer index. That is Kramer index. So always remember that jaundice first appear at the head region, then it moves downward, and it is more initially centrally as compared to peripherally. Now let's first understand the Kramer index. So what is Kramer index? So there are different stages in the Kramer index depending upon the severity of the jaundice. So now let's discuss the Kramer index. Now in Kramer index there are different stages, like there is stage 1, stage 2, stage 3, 4 and 5. Now in stage 1 there is yellow discoloration of head and neck. There is yellow discoloration of head and neck. So in stage 1 Kramer index there is yellow discoloration localized to head and neck. Here the serum bilirubin level is 4 to 6 mg per dl. So it is important. Secondly, in stage 2 the yellow discoloration localized to upper torso. Torso means the main parts of body like chest, abdomen, pelvis and back. So here the yellow discoloration localized to upper torso, and the serum bilirubin level, that is 6 to 8 mg per dl. Now coming toward the stage 3, here the yellow discoloration localized to lower torso and upper thigh. So here in stage 3 the yellow discoloration of lower torso and upper thigh, and the serum bilirubin level here is from 8 to 12 mg per dl. Now in stage 4 there is yellow discoloration of legs and upper arms, and the serum bilirubin level is in the range of 12 to 14 mg per dl. Now in the last there is stage 5. Here the yellow discoloration, it is localized to the palms and soles, and the serum bilirubin level is more than 15 mg per dl. I repeat, there are 5 stages in Kramer index: stage 1, 2, 3, 4 and 5. In stage 1 the yellow discoloration localized to head and neck, and stage 2 the yellow discoloration localized to upper torso, and stage 3 the yellow discoloration localized to lower torso and upper thigh, and in stage 4 the yellow discoloration localized to legs and upper arms, and at the last at stage 5 the yellow discoloration localized to palms and soles. So it is important. Now let's come toward the physiology of neonatal jaundice. What is the physiology of neonatal jaundice? So how bilirubin is formed actually? Let's discuss the physiology of neonatal jaundice. Now, as you know that, let's suppose this is a RBC, and RBC normally it is a biconcave disc and having diameter 7.2 micron. Now, what is the composition of RBC? So composition of RBC is like 35% it consists of hemoglobin, and 2.5% it consists of others, like it may contain glucose, amino acids, proteins, etc. And 62.5% it consists of the water. Now, when there is RBC destruction, what happens? So when there is RBC destruction, so already the water gets dissolved in the blood, while the remaining product is hemoglobin. So ultimately the hemoglobin is formed, and that hemoglobin later it become bilirubin, and when this bilirubin level is exceed in the blood, it ultimately lead to the jaundice. So let's come toward the main pathophysiology of neonatal jaundice. So let's discuss the pathophysiology. Now spleen is actually, as you know that spleen is very vascular organs, and it is considered as a graveyard of RBC. And why it is so? Because in spleen there is RBC destruction occur. For example, this is a spleen. Now spleen, the most important point is spleen is highly vascular organ. Secondly, it is considered as a graveyard of RBC, meaning that it causes destruction of red blood cells. Now, if this is spleen, so inside spleen there is specialized kind of cells present in the spleens, and that specialized sort of cells that is called as, yes please, that is called as reticuloendothelial cells. This is called as reticuloendothelial cells. Reticuloendothelial cells. And what is reticuloendothelial cells? These are RBC phagocytic cells. These are RBC phagocytic cells. What does it mean? It means whenever spleen is crossed through splenic capillaries, so ultimately there is RBC destruction occur. Let's say we have an old RBC. By old RBC, I mean to say RBC having lifespan more than 120 days in adult, and RBC having lifespan more than 80 days in child. So let's say we have an old RBC. Soon as when these old RBC, it passed through splenic capillaries. So what happened? When it passed through splenic capillaries, so in the spleen we have a reticuloendothelial cell which is responsible for destruction of RBC. So what happens? That there is RBC destruction occur. There is RBC destruction occur, and whenever RBC get destroyed, it get disrupted, so the end product is formed. End product is formed, and that end product is called as, yes, that is called as bilirubin. The bilirubin that is formed here, this bilirubin is called as, that is called as indirect bilirubin. This bilirubin is called as indirect bilirubin. It is also called as unconjugated bilirubin, or it is called as water insoluble bilirubin. So now, if there is water insoluble bilirubin, it means the bilirubin is not soluble in water, so there is no excretion in bilirubin through stools and urines. So what happens as a result of this, body start compensation. So what happens? Body start compensation and excrete bilirubin outside body. Now, let's suppose this is a spleen. Now, as I discussed earlier, whenever RBC pass through spleen, so there will be RBC destruction occur. As a result of that, the end product is formed in the form of bilirubin. The bilirubin that is formed inside the spleen, that is called as indirect bilirubin or unconjugated bilirubin or water insoluble bilirubin. So this is now this bilirubin it would reach to the liver. So let's say this is a liver. Now the transportation of this bilirubin it would reach to the liver. So the transportation of this bilirubin from the spleen to the liver, it is not independent. This bilirubin, when it gets transferred from spleen to the liver, it would require a specific proteins. This is very important point. It would require a happy protein, and that is called as albumin. This is called as albumin. So it is important. The transportation of bilirubin from spleen to liver, it required a specific protein that is called as albumin. So just imagine if there is protein deficiency, so what would happen? The transportation of bilirubin from spleen to liver, it would not occur. So what happens? Ultimately, the unconjugated bilirubin level, it is increases. And that unconjugated bilirubin level, when it increases, it would lead to the phenomena of jaundice. Now let's say, for example, this bilirubin, it reached to the liver. So for that, the bilirubin would reach to liver through portal vein and splenic vein. Those portal and splenic vein, it would combine together, and ultimately this bilirubin, it would reach to the liver. Once this bilirubin comes and it lies within the liver, so after that, the liver has a specific enzymes. Now this liver, it has a specific enzymes, and that enzyme is called as UDP-GT. So what is UDP-GT? It is a uridine diphosphate glucuronyl transferase. Now what is the major function of this UDP-GT? The major function of UDP-GT is when unconjugated bilirubin that is come from the spleen, it converts the unconjugated form of bilirubin into the conjugated form of bilirubin. Now this unconjugated bilirubin, it would convert into conjugated bilirubin. Now the bilirubin that is formed here, that is called as direct bilirubin, or that is called as conjugated bilirubin, or it is called as a water soluble bilirubin. So the major function of this UDP-GT is very important. This UDP-GT, it is responsible to convert the unconjugated form of bilirubin into conjugated form of bilirubin. Now how actually the bilirubin is excreted from the body? Now let's discuss the excretion of bilirubin. Now liver has, as you know, that liver has two lobes, that is right lobe and left lobe. Now let's say, for example, this is a liver. This is a rough diagram, but just consider this is a liver. So this is the right lobe of liver. This is the left lobe of liver. This is the right lobe of liver. This is the left lobe of liver. Now from liver there is two ducts. The first is called as right hepatic duct, and this is the left hepatic duct. Now right hepatic duct and left hepatic duct, they combine together to form common hepatic duct. So this is a right hepatic duct. This is left hepatic duct. Both combine together to form common hepatic duct. Now this is common hepatic duct, let's say. Now as you know that from the right lobe of liver, posteriorly and inferiorly, there is an organ that is called as a, from posterior inferior aspect, there is an organ that is called as gallbladder. And gallbladder, it is the reservoir of bile juice. Now there is a specific duct that is arise from the gallbladder, and ultimately this duct, it combined to the common hepatic duct. Soon as when common hepatic duct combined to the duct that is arise from the gallbladder, so that would become the common bile duct. And the duct that is arise from the gallbladder, that is called as a cystic duct. Now when cystic duct combine together with the common hepatic duct, it becomes common bile duct, and ultimately from the pancreas, the pancreatic duct mixed with the that is pancreatic duct, it is mixed with the common bile duct, open into ampulla of water through the sphincter of OD. It reaches to the small intestine and ultimately it reaches to the large intestine. Now, from the large intestine, this bilirubin is excreted now from the body. Now, it is being reported that in 80% cases, the bilirubin that is excreted from the body, that is, in 80% cases, the bilirubin is excreted in stool, and that is called as stercobilinogen. While in 20% cases, the bilirubin is reabsorbed and excreted in urines called urobilinogen. So it is important. How bilirubin is excreted from body? Always remember that in 80% cases the bilirubin is excreted in stools in the form of stercobilinogen, while in 20% cases it is excreted in urine in the form of urobilinogen. So it is all about the pathophysiology, that how actually the bilirubin is excreted. Now let's discuss the types of neonatal jaundice. So now let's discuss the types of neonatal jaundice. So there are two types of neonatal jaundice. That is called as physiological jaundice and pathological jaundice. So there are two types of neonatal jaundice: physiological jaundice and pathological jaundice. So the most common type is physiological jaundice. It is the most common type of neonatal jaundice, that is up to 95% cases. While pathological jaundice, it is less common and it is present in 5% cases. Secondly, physiological jaundice, it is a self-limited disease. It is self-limited disease, meaning it resolves spontaneously and there is no specialized sort of treatment is required in case of physiological jaundice. While in another hand, pathological jaundice, it is not self-limited disease. It required treatment. Now, clinically, jaundice appear in case of physiological jaundice, and physiological jaundice clinically, jaundice appear after 24 hours of baby's birth. So it is important that in physiological jaundice, it is always occur after 24 hours of life of a baby. While in another hand, in pathological jaundice, the clinically jaundice appeared within 24 hours of baby birth. Now, what are the major causes of physiological jaundice? So the major causes of physiological jaundice, that is immature, the most common cause of physiological jaundice, that is immature liver. Immature liver. Also, there is UDP-GT deficiency or ligandin deficiency. I will be discussing it in a while in detail. So till now, just remember the most common cause of physiological jaundice is immature liver. Also, the UDP-GT deficiency or ligandin deficiency can cause the physiological jaundice. While in another hand, if we talk about pathological jaundice, the most common cause of pathological jaundice are RH incompatibility, ABO incompatibility, and hemolytic diseases and hypersplenism. So the major causes that is being reported in pathological jaundice, that is RH incompatibility, ABO incompatibility, hemolytic diseases and hypersplenism. Now in case of physiological jaundice, let's suppose if there is baby and the baby is term or preterm. Let's say if baby is term. Term means having mother period of gestation equal to 37 weeks, while in preterm the period of gestation it is less than 37 weeks. Now there is 60 to 80% chance there is 60 to 80% chance of a preterm baby to develop the physiological jaundice. So it is important. Secondly, if baby born at term, so the serum bilirubin level here it is more than 5 mg per dl while less than 12 mg per dl. While at preterm, if baby has physiological jaundice, so it would be more than 5 mg per dl and less than 15 mg per dl. So if the baby birth is at term, so and if the baby has a physiological jaundice, so the value of serum bilirubin would be more from 5 mg per dl but less than 12 mg per dl. But if baby birth is at preterm, in that condition the serum bilirubin will be more than 5 mg per dl or it would be less than 15 mg per dl. Secondly, the peak bilirubin and physiological jaundice, peak bilirubin value in physiological jaundice, that is 5 mg per dl. And in physiological jaundice, the palms and soles are spared. Palms and soles are spared. They are not involved. Now, if the baby is suffering from physiological jaundice, so there is no specialized treatment is required, and they are conservatively managed. Now, here physiological jaundice disappear at 7-day and 14-day of child life or age. So if a baby has physiological jaundice and if the baby is at term, so if the baby is at term, the physiological jaundice will be disappear at 7-day age of the child. But if a baby is preterm, so the physiological jaundice will disappear at 14th day of life. So it is important. Physiological jaundice will disappear at 7-day at term, while physiological jaundice will disappear in babies who are preterm at 14th day. So this is in 7-day for term, while for 14th day it is for preterm child. So I repeat, in physiological jaundice, it is most common type. It is self-limited disease. Clinically, jaundice appear after 24 hours of baby's birth. The most common causes is immature liver. There is UDP-GT deficiency. There is ligandin deficiency. If the baby is at term, there are 50% chance to develop the baby physiological jaundice. If the baby is preterm, so there is 60 to 80% chance of dead baby to develop physiological jaundice. Also, the palms and soles are spared. It is important. Also, the physiological jaundice will be disappear at 7-day and at term, and it would disappear at 14-day for preterm child. So that's all about the physiological jaundice, and we will be discussing the pathological jaundice in detail in upcoming series of lectures. But till now we discussed the physiological jaundice. Now we will be discussing the major causes of physiological jaundice. So now let's coming toward the causes of physiological jaundice. What are the causes of physiological jaundice? So the first cause is increased load of bilirubin on hepatocytes. It is the most common cause of physiological jaundice. Now, causes of physiological jaundice. Now, the first is increased load of bilirubin on liver cells. Secondly, there is failure of excretion of bilirubin, Thirdly, there is deficiency of UDP-GT, that is uridine diphosphogluconoryl transferase. So, as I discussed earlier, the major function of UDP-GT is convert the unconjugated form of bilirubin into conjugated form of bilirubin. If there is deficiency of UDP-GT, so the unconjugated bilirubin level will be exceeded. Ultimately, there will be jaundice. Fourthly, there is a deficiency of specific protein that is called as ligandins. As I discussed earlier, the transportation of bilirubin from spleen to liver, it is not independent. It's always depending upon a specific proteins. So these ligandins also it play a role in transportation of bilirubin from the spleen to liver. So if there is deficiency of ligandin, so bilirubin is not able to move from the spleen and liver. So ultimately there will be no conjugation of bilirubin, so bilirubin level exceeded and it would lead to the jaundice. Now coming toward the specific sign and symptoms of physiological jaundice. So let's discuss the signs and symptoms. So what are the signs and symptoms of a patient that is suffering from neonatal jaundice? So the major symptoms in terms of the major complaint is there is yellow discoloration of skin, mucous membrane and sclera. There is yellow discoloration of nail beds in the terminal end of the nail. Also there is light color stools. Light color stools, normally the stools color is yellow or black, but here there is light color stools, and there is poor feeding. Also fever, lethargy, restlessness and high pitch crying. Inability of weight gain. Initially jaundice appeared upward like in a region of head, then it shifts toward in a downward direction. Already we discussed it previously in the Kramer index. So jaundice first appears in the head region, then it shifts toward in the downward direction. So what are the signs and symptoms of neonatal jaundice? The first is there is yellow discoloration of skin, mucous membrane and sclera. There is also the yellow discoloration of the terminal portion of the nails. There is light color stool in the neonatal jaundice, poor feedings. Also there is fever, lethargy, restlessness, high pitched cry, and there is inability of weight gain, and the jaundice first appear at the head direction, then it moves downward. Also there is initially it is more in the centrally and then it moves toward the peripherally. Now this is the sign and symptom. Now coming toward the treatment of the physiological jaundice. Now what is the treatment option for the physiological jaundice? So usually let's discuss the treatment option. So first, suggest the mother to continue the breastfeeding. It is important initially suggest mother to continue breastfeeding. And proper care to the child. Now, if the serum bilirubin level exceeds more in the blood, so we have a certain pharmacological approach as well. So for that, we have a first approach, that is injection phenobarbital. We can give phenobarbital. Now, there is two main functions of the phenobarbital. First, it improves the function of liver. So ultimately, there will be proper excretion of bilirubin, so the jaundice will be resolved. Secondly, it also improves the function of ligandins. And what is ligandins? It is a specific proteins which is required for the transportation of bilirubin from the spleen to the liver. So if it improves the function of ligandins, so bilirubin can be converted into the from the spleen to the liver. So ultimately the unconjugated bilirubin level decreases and the jaundice will be resolved. So secondly, there is another treatment, that is phototherapy. So phototherapy is the most common medical treatment option. In phototherapy, the light is passed on baby. So what happens? There is degradation of bilirubin occur. There is degradation of bilirubin. Ultimately, those bilirubin is excreted from body of baby and stools and urines in the form of stercobilinogen and urobilinogen. So in phototherapy, light is passed on baby. Ultimately there is degradation of bilirubin, and that degradation of bilirubin lead to excretion of bilirubin from body in the form of stercobilinogen and urobilinogen and stools and urine. Now in phototherapy we use two lights. First is blue light and white light. In phototherapy, we use blue lights and white light. The blue light, it is responsible for degradation of bilirubin. While white light, it is used for observations. So don't forget the point. In phototherapy, we use two set of lights. The first is called as blue lights. And what is the major function of blue light? It is responsible for degradation of bilirubin. Secondly, we use white light, which is used for observations. Now, there is another important question. What is the distance between the light and baby? So the distance between the distance between baby and light is 45 centimeter. It is very important. Secondly, there is another question, the light that is used for phototherapy in case of neonatal jaundice, that is, what is the wavelength of that light? So the wavelength of light is 460 to 490 nanometer. So it is also very important. So the distance between baby and child is 45 centimeter, the wavelength of light is 460 to 490 nanometer. Now the third approach is, that is blood transfusion. But blood transfusion is very rare in physiological jaundice. Till now, in treatment of physiological jaundice, we said that we have three approaches. The first is injection phenobarbital. Secondly, there is phototherapy. Thirdly, there is blood transfusion. So students, that's all about the physiological jaundice and neonatal jaundice. And upcoming series, we will be discussing the pathological jaundice in detail. So hopefully you will like the video. Thank you so much.